Well, first of all, thank you very much for the opportunity to present the initial findings from a piece of ongoing research that I've been working with PenCLAHRC on investigating young people and children's experiences of hospital-based communication. I'm presenting this research on behalf of PenCLAHRC, which is the Peninsula Cerebral Research Unit, based at the Peninsula Medical School at the University of Exeter. I'm a qualitative methodologist, and so I'm going to give you a wee bit of background about the drivers for this study, and then I'm going to tell you a wee bit about how we went about it, and then move on to present some of the emergent findings. Other members of the team that have worked with me on this study are Claire Lloyd, who's the research fellow that's been carrying out interviews and undertaking the analysis with me, and also Chris Morris, who you've just heard from, who's the principal investigator of the study, and also Camilla McHugh, who's been a very invaluable coordinator helping with recruitment and so on. We've also been very lucky to have a fantastic set of advisors in the PenCLAHRC family faculty, and that includes family members and also paediatric healthcare professionals. So the research I'm going to talk about is part of a programme of research being carried out by PenCLAHRC to improve communication between staff and disabled young people in hospital. And it's also supported by PenCLAHRC, which is a collaboration of NHS and the University of Plymouth and Exeter. The background to this study is a literature review that members of PenCLAHRC carried out to assess what we know about communication in hospital between staff and disabled children. And they also wanted to identify any gaps in knowledge in this area. And a number of key concerns emerged from that literature review about negative interactions between staff and parents and children with disabilities. Concerns that families weren't being given sufficient information about their child's needs and their child's treatment or condition, and also concerns about inadequate involvement of young people and children in making decisions about their own care. So a three-stage programme was developed, which included the review, the study I'm going to talk about today, which will hopefully lead into the development of an intervention and training for staff to help improve communication with young disabled children in hospital. So the aim of our study is hopefully a positive one, which is to contribute to the improvement of communication with disabled young people. And our objectives include investigating experience of hospital-based communication. So we're not trying to measure anything. We're trying to help increase understanding of and provide evidence and examples of experiences of communication and the things that parents and young people say make a positive difference to them in hospital communication with staff. And we also want to look at the influences on hospital-based communication as well. So the key questions that we tried to address in our study include: where disabled young people given and their parents given information, and were they involved in decisions about their care? What aspects of staff communication were perceived as good or bad, but we're particularly interested in what parents felt worked and what helped communication. And we're also interested in how staff experience communicating with disabled children in hospital, because they are part of the context of making communication as good as it can be. So in order to answer our research questions, we needed to access the views and experiences of young disabled people and children and their parents, as well as professionals. So we chose a qualitative approach to enable us to get to that lived experience and to increase our understanding. And an interpretive case study design allows us to investigate hospital communication from different perspectives and to ultimately compare similarities and differences, for example, between what parents say equates to good communication and how staff experience that. And in a sense, we're coming from what's known as a realist perspective, because we're interested in learning about the ways that people already work well together in any areas of difficulty. And we're interested in the contextual influences that people attribute to their behaviours and experiences, such as the settings, the resources, the organisational systems and skills that parents and professionals and young people talk about as being important. So it's really about what they feel is a priority around communication. And so we're going for a contextual understanding of hospital-based communication. So, within our research, we obviously wanted to take account of the very sensitive nature and setting of the study. So ethics was really important to us. Consent was sought from all participants, and also as assent or agreement from the young people. And we were aware that a lot of the young people and children that we might talk to would have non-verbal communication. So we also wanted to make sure that we could get agreement from them to the best of their ability. So we also videoed the consenting process with the young people and children as well. And as part of the preparation for this study, we also wanted to be able to stop interviews to avoid over-distress in the parents and the young people that were part of the study. So we rehearsed a way of stopping interviews if necessary, and we worked with the young people, children's familiar communicator, so that by piloting a way of kind of going and seeing the young person and familiar communicator before the actual interview, so we could get to know them and we could work with them so that they could find ways that suited them to stop the interview if it became too distressing. An ethical approval was granted by the South West Research Ethics Committee in February 2010. I was under the air freshener spray when the guy came round with it, and it's really affected my throat, so I'm just going to have a wee drink of water. So the sample for our study was purposive, and that means that we wanted to get participants in our study that could give us their experiences of hospital communication. And we wanted to sample young people and parents of young people who've had a recent experience of hospital admission within 1 month. And also we wanted to get to staff, talk to staff from a range of disciplines. We recruited through district general hospitals in Devon and through school nurses linked to schools for young people with disability. And to date, we've interviewed 4 young people, and we're hoping to interview 3 more in the next month or so. We've spoken to 15 parents, 9 professionals individually, and we've also had 2 group interviews, one which was a group of doctors, hospital-based consultants, and another that was allied health professionals working in hospital settings. So we've got quite a range of participants that we've spoken to in our study. So we accessed experience and views through face-to-face individual and group interviews, focusing on key experiences and what parents and young people and staff feel help or hinder good communication, and what they thought might be areas for improvement and any recommendations that they felt they could make. And myself and Claire carried out a thematic analysis, and we used a thing called framework approach, which helps you organise your data for data management purposes when you're collecting experiences. And that approach uses matrices to help you organise data, and it's really good for helping you look at patterns in what people are saying, so you can look at similarities and differences and perceptions and views and experiences. And I'll show you a couple of those in a minute. So Claire and I began by our analysis by coding to really try and describe the data and to shape the data into themes about communication. And we summarised these themes for the different groups of people that we had, for professionals, parents, and we're just starting to do that when we transcribe the data for the young people. And I'm going to look at some of these findings now. So as promised, here's one of the matrices. So what you're seeing here is a matrix that contains some of our initial descriptive themes around what the parents' data is telling us about their experiences of hospital communication and what was important to them. This is one of a number of matrices that Claire and I have coded, and what we did was we code the data or the transcripts independently, and then we agree a consensus in terms of what the themes, what patterns we're seeing, what themes of experience we're seeing in the data. So along the top there you can see some of the themes, and then down in the columns are the sub-themes that relate to each of the main themes. So examples of those are things like, parents' world, which includes things like experiences of hospital, emotions, parents' roles in hospital communication. Things, not surprisingly, one of the main themes was communication. Another theme was family and friends, which includes sub-themes like issues around relationships with family members, relationships with friends, in terms of hospital experiences, and support from outside the ward. So once we'd done the initial analysis of coding the data and breaking what parents were saying into themes that were important to them, this slide shows how we then grouped those themes together into what's known as categories. And I just want to say a wee bit about what a category is relative to a theme. A category is a phrase or term that encapsulates or represents a grouping of themes or sub-themes that seem to go together in some kind of meaningful way, held together by a concept or an idea. So at this stage of analysis, what we do is we consider which themes fit or can be included within distinct categories so that we can increase our understanding and help address the research questions of a particular study. So in this case, we're interested in which categories the themes might come together into, which way we can group the themes that help us understand hospital communication more fully. So this is why in qualitative research, checking whether emerging categories have resonance or make sense is really important to qualitative researchers, because it enables us to do a validity, or in qualitative terms, a credibility check with participants and perhaps other researchers in the field through, for example, feedback meetings or dissemination. And again, you can see that across the top we have three key categories: knowing, communication, and child's eye view, with down the columns the themes that we developed from the first stage of the analysis grouped together to try and make some sense of how parents may be experiencing hospital communication and what might be important to them. So we have three key categories: knowing, which includes themes such as getting to know the child, or making contact with the child, building rapport. Because parents really felt that getting to know the child was really, really important in getting communication to be as good as possible with staff and hospitals. Again, not surprisingly, given the focus of our study, a key category was communication. And the sort of idea or concept which links the themes in this category are what parents regarded as crucial to good staff communication, such as utilising the capabilities of the young person to the best of their ability, listening to parents, and, for example, there is almost a checklist of good communication skills, like using non-verbal skills, using your body, positioning and things like that. And the third key category was child's eye view, which are really grouped together because they represent a child-centred view of the world, these themes, and prioritising things like the emotional experience of hospital, maintaining relationships with the child's family, or helping the child make choices. I'm just going to look at some of those in more detail because there's quite a lot of information, as you can imagine, so it's really just a flavour of what we found. So this is a visual representation of category 1, knowing, and this category represents what parents talked about in terms of how important it is for staff to get to know their child as much as possible. Parents did talk about professionals not knowing their child or not knowing their child's needs or their capabilities, and as well as things like the length of time that a member of staff knows a child can also make a big difference to the nature of the communication with that child. And parents definitely linked getting to know their child with good communication. in the sense that that enables the member of staff to tune into the child and helps them talk to the child in a way that suits them. Parents, however, also showed good understanding, a clear understanding of how difficult it is for professionals to get to know children in the context of a busy ward. We know it's not easy. Parents shared that they know it is not easy for professionals to get to know children. They also talked about different experience, the different levels of experience that a member of staff has in terms of how long they've worked with kids or the training they've had, as making a big difference to meeting the child's communication needs on their terms. So there is a sense, really, that parents felt that getting to know the child and good communication were intertwined. And this is just one illustration of one of the themes, making contact. Parents highlighted the difference that proactively trying to get to know a young person can make and to how they experience communication and how a member of staff can connect with a young person. And they suggested that getting to know their child can also help mitigate or lessen the negative impact of that busy ward. So, for example, parents suggested that trying to match a child up with a member of staff that maybe knows them from a previous admission can help mitigate the busyness of a ward, because that member of staff will know them better anyway. So I'll just read it out, but that is something that does mean a lot. It is making sure that they will look at the name and see whoever the young person is and ask, have we had this patient before? Yes, we have. Who dealt with her? Okay, is that person available? And so this has implications maybe for how staff might be allocated if they know that a child's been admitted into hospital, for example, for a routine examination. Another key category, communication. And this, in a sense, encapsulates the essence of what parents regarded as good communication around staff attitudes and behaviours and the actual skills that staff were able to use. Like, for example, making eye contact with a child, but also acknowledging that that maybe doesn't suit every child. So again, knowing a child's communication capabilities and likes is really important because, okay, I'll move on. So again, you can see how the themes kind of come together to highlight what it is that parents prioritised. And again, this is an extract of how parents could be very, very specific in how they thought that members of staff could communicate with their child. Got to make sure he's looking at you when you're talking to him. That is the biggest thing. Sometimes you can tell that he is understood or he is not understood by looking at him. And with him, I think that it is important that the child is actually looking at you when you're speaking. And that, I think, is the biggest thing, as from that, you can gauge whether they are paying attention and whether they are taking it in. And the third category, I shall have to start speaking really quickly now. And again, you can read that for yourself, but what this highlights is that, for example, the medical or treatment need that a child may be in hospital for isn't necessarily what that child prioritises for themselves. So things like acknowledging that a child may feel scared, acknowledging that they want to keep contact with their parents, acknowledging that parents talked about the difference it can make by giving a wee bit of control back to a child, by giving them choices, and that can be like a really simple thing, maybe even just choosing food or a TV programme. And also, one of the themes that emerged that were important in the child's world was that, as I said earlier, that emotions are really important as well, and that children remember bad hospital experiences. So if staff can realise that and try and make it an emotionally positive experience, that can be very helpful as well. I'm going to have to definitely rush on it, because what I want to do as well is and let you see some of the initial findings. We're not as far on in the analysis of the professional interviews and group interviews as we are with the parents, but we do have some emerging findings. that I think would be interesting, and what we would like to do eventually is obviously compare similarities and differences and look at the key processes that can help communication. But essentially, medical professionals in particular talked about a variety of specialist communication training in their undergraduate training, but that was really a small part of their overall training. Nurses, their training in working with disabled children and in communication, they also had training, but that tended to be postgraduate, but again represented very little of their overall training. Professionals did have a good understanding of the importance of involving young people in decision making, but that varied in terms of how different professionals viewed this. For example, doctors felt that they were there to treat and felt guilty about not being able to have the time to talk to children. Nurses felt communication was central to their role, but they didn't have time either. So both all the groups of professionals that we talked to felt guilty about not having the time to focus on a young person, on good communication with young people. Another finding that's emerged is that good communication is crucial in emergency situations, but the use of things like communication passports was inconsistent, and who was responsible for those was uncertain as well. And professionals also were aware of the importance of parents as a source of information and as communication mediators. And they understood that if parents got frustrated and fed up with the professionals, because they know that parents want the best for their child. So in a sense, what the two sets of data, the parents and the professionals, is seeming to show is that there is a co-understanding of how difficult it is. And I've said that already. We are going to try and look more and draw at similarities and differences, what seems to make a difference to good communication, and try and draw that out to help improve communication. I did want to say as well that, again, it's because I'm a methodologist, one of the things that's been really exciting with this study is that it's allowed me and Claire to develop a procedure to really try and hear the voice of young disabled children who have poor verbal communication. So we've been piloting procedures of videoing young people along with their familiar communicator so that we can really get their voice into our study, and that's working really well at the moment. So key messages, parents and other guardians or carers can help professionals know their child and can advise on communication strategies. And they are sympathetic, parents are sympathetic to the constraints on professionals in a busy hospital environment. Professionals do want communication to improve, they know it needs to improve, and they recognise parents' concern and agree that change is needed, but they too work within a context of needing to be realistic about resources and challenges around time and staffing. The different professional groups that we spoke to expressed guilt and concern over lack of time for communication, but there were different reasons for this. And our challenge is to build on these emerging findings and hopefully develop an intervention that focuses on the positive things that help good communication. Thanks very much.